So just give a little of my background. While I was in medical school at University of Illinois in Chicago, started meeting with a community group on Chicago's west side in a community called North Lawndale. North Lawndale is the community that when Martin Luther King came north in 1966 to demonstrate that housing discrimination was not limited to the South, he lived in North Lawndale for several months. That community was ravaged in 68 with the riots. All the commercial strips were burned to the ground and largely had not been rebuilt. When I was in medical school, a group from that community, basically out of a church that I helped to start, were concerned about the needs in their community. So one Sunday morning, the pastor put up a blackboard and said, what are the needs in our community? We need to continue to preach on Sunday morning, but we also need to demonstrate God's love and concern. First thing that went up on the blackboard was a safe place for laundry. North Lawndale was separated north and south by a street by two gangs. There were, in the first 2.5 years, actually, the clinic started, there were 84 murders in an area that was literally 4 square miles. So the first thing went up on the blackboard was a safe place for laundry. The first ministry we were meeting in a storefront was to get people to donate washers and dryers. We put them in the church so women had a safe place to come and do the laundry. But the second thing that went up on the blackboard is we need a place for affordable primary care services. Uninsured and poor, in 1978, you could go to Cook County's emergency room. They would diagnose your heart failure, diabetes, whatever it was. And if you weren't part of their system, it was 6 months as an adult to get an appointment. So there's huge disparity in terms of health access. There were obviously a huge disparity in terms of health outcomes as well and health status. And as a medical student, I was kind of focused on the access part, but I had gone to medical school with the intent to go overseas and do third world medicine. I had just returned back from 3 months in Liberia at the beginning of my 4th year, working at a mission station when that blackboard went up. Everyone kind of looked at me and said, well, you can do something about that. You're a medical student. I said, no. I had done my training in Chicago, so I thought, if we're going to go overseas, let's go to live someplace different, maybe a little warmer climate than Chicago. But the more my wife and I prayed about it, the more we decided that was what we would do. So moved into that community, doubled the white population from 2 to 4. But the patients in our community, the people in our community really reached out to us. We felt like if we were really going to be effective, John Perkins was coming by, was really influential with his 3 R's, the first which was relocation. We definitely understood that and felt like that was important. So lived in that community for 34 years, raised our family there. The health center started when I finished training in 1984. We started with 5 staff. And there were, we had no special funding except for local foundation dollars and Robert Johnson money, amounted to $100,000 a year. I was making $25,000 as a resident, thinking, okay, we can do this. We only have 5 staff. You should be able to get $25,000. I mean, I had no idea what we was doing, right? We were so poor we could not afford malpractice insurance for the clinic. We started in a clinic in a building that used to be Emo Denimark's Cadillac dealership. It was burned down during the 68 riots, or damaged severely. The Salvation Army was in there. Salvation Army wasn't keeping up, and the building was condemned to be torn down. We actually were meeting across the street in a storefront as a church, got that building for $25,000. And rehabbed it all with volunteers, including then our initial clinic, which was 5 exam rooms. So the building had our clinic. It had what now became the church building, and the kids really wanted a gym. And so we dug out a full-size gym by hand, down 6 feet, to be able to have a gym. And that's how we got started. We got paid. We charged $5 for the uninsured. And we, on a sliding scale, and we were paid $13.65 from my Medicaid for a 99213 visit. So things were a little tough, but God really provided for us. And it was really a community effort. So a lot of the kids, including some of them that were in the gangs, were actually the kids that actually rehabbed the building. They owned the building. There was never any graffiti on that building. And it was a story of really taking the community and the community coming together to decide this is a need of ours and this is a need we're going to meet. So that's kind of the background. We got involved with value-based payments and value-based care in 1987. Nobody was doing that at that time, very rare, except one of the Medicaid agencies, Illinois at that time, had voluntary managed care. They came and said, well, would you like to be part of our provider network? And we said, well, tell us about that. And they said, well, we're all Medicaid. I said, well, that's pretty good because that'll increase my payer mix. I was 50% uninsured. But they said, oh, by the way, we pay capitation. I said, what's that? Somehow that didn't get into my medical school curriculum, what capitation was. But they were going to pay me a per member per month basis to provide primary care services. So I said, well, it can't be any worse. I don't remember what it was like $7 or $8 or something like that a month. But I figured, well, it can't be worse than $13.65 a visit. So that's how we got started. They then had this strategy which said, you know what? We think that you need to be accountable for care and outcomes and patients. And so every year they would increase our responsibility in terms of our capitation, take it or leave it. So over 5 years, I don't remember the exact order, we became financially responsible. It was a really pretty small clinic for not only primary care, but specialty care, outpatient diagnostics, behavioral health, all pharmaceutical expense, the ER, both professional and facility charges, and took upside and eventually downside risk for inpatient care as a single FQHC. We learned how to provide convenient access to care because if we weren't providing convenient access to care, people were in the emergency room and we were paying the bill. And it was all about how do we provide timely and convenient access to care, help people manage their chronic conditions, and because if they didn't, then we were financially responsible. We did that for Medicaid initially in 1996. Medicare went to managed care. Same companies, Humana, WellCare, United, which we were already contracted to do that for Medicaid, gave us those contracts for Medicare and also their commercial. Did it for Blue Cross Blue Shield commercial population as well. So it always kind of made sense to us, which is to say, we're not going to tell you how to provide your services, but we expect you to provide services. We expect you to improve patients' outcomes and access to care. And if you can be creative in terms of how we provide, what venue we use, it didn't matter whether it was billable or not. We could be creative in terms of what members on our care team provided care. We're no longer limited, as long as it was clinically appropriate, to say, well, the doc's got to do this part, because if the doc doesn't do it in a face-to-face, in-person visit, because there was no telehealth back then, like people have to come and sit in my waiting room for me to get these services, and it's got to be done by the doc or I don't get reimbursed. That all went out the window. Our health center and 4 others in Chicago built the first capitated APM in 2001 for FQHCs in the country. Because what was happening is there's something called a RAP payment, which is the difference between your PPS and counter rates, which are and the Medicaid fee schedule. That RAP was being paid fee for service by the state. Everything else was being paid caps. So we went to the state and said, well, let's take that revenue and turn it into a prospective per member per month basis. So, and that again got us off the wheel of sort of saying fee-for-service method is the way that we're going to get reimbursed versus pay us and hold us responsible for improving patients' outcomes. So that's kind of the background I'm going to come with today. As you may or may not know, because you all look pretty young to me, which is in the late 90s, early 2000s, society swung back away from managed care. There was good reasons for it, because at that time, most of the capitation was paid regardless of what the outcomes were. And so you're getting rewarded for reducing access to care in some cases. So the same individuals that would be churn visits under fee-for-service that weren't necessary to get money would do the same, just the opposite when it came to paying them capitation. But we have swung back to realize, and we're going to talk a little bit about that we have to change the way we provide access to care, because we no longer have the workforce to be able to serve the increasing needs of our population. And when there's a shortage of workforce, it is communities like ours that will fill its shortage first. So with that kind of background, let's go ahead and get started. When we proposed this particular title, it was before the election. I was thinking very different in terms of changing societal expectations, but I do want to make hopefully a bit of a political comment for my first couple of slides before we get into it, hopefully not offending anyone. Which, when I was preparing my slides, I read Health Catalyst. I don't know if any of you read the New England Journal Health Catalyst. It's a free publication that comes out pretty frequently that looks at new healthcare trends and stuff. I would encourage you to read it. If you're not, it's totally free. You don't have to pay a subscription to the New England Journal for it. But this came out a week ago, just as I was preparing my slides. And it said, and it really talks about changing societal expectations. Universal values such as human dignity, freedom of speech, and security of person, which for decades have been the basis for peaceful coexistence within and among nations, are being carelessly relativized and fundamentally challenged in more and more places. As a result, we are confronting with growing injustice, inequality, and insecurity. It is the weakest and the powerless who pay the highest price for the lack of orientation of the powerful toward universally valid values. We are under a lot of pressure as health centers to scrub our websites, make sure we get rid of anything that is related to diversity, inequities, inclusion. We have to resist that. There's a lot of attempt to be able to make that become the norm in this country. We have to resist that with everything we can. Even the National Association of Community Health Centers came out and urged their health centers that their funding may get jeopardized if they talk about anything related to DEI. We need to stand up against that. That is not certainly what Christ has taught us to do. But he went on to say, which is really the paradigm. So that's the societal change. Unfortunately, the paradigm change, though, is that in healthcare, too, we must be careful not to lose sight of the universal promise of good care for all those in need, regardless of race, color, sex, religion, and national or social origin. It is imperative that healthcare systems practice value-based care in order to achieve the best possible health outcomes for all at a reasonable cost for societies. Patient-oriented care models are just as important as innovative reimbursement solutions that reward good quality care and thus encourage its use. So I gave a presentation a couple of days ago at the executive leadership about what's happening in terms of payment. I'm going to just touch on that really briefly, but mostly what I want to talk about today is how are we doing on the delivery side? How are we doing in terms of providing timely, convenient access to care that really is improving patients' outcomes? And what are some models that should come out that we need to start to consider in terms of how we can improve the way we're providing this kind of care? So equity, I think probably most of you have seen this. This has been around for a long time, but I think we all practice equity. I think even Trump practices equity. It's just who does he care about? We practice equity in terms of people that we care about. So who of us would take our two kids to watch a baseball game and one of them is too short to be able to see the game? It wouldn't adjust. I mean, equity is all about not treating everybody equally. It's all about making sure everybody has an equal chance to optimize their healthcare outcomes when it comes to healthcare equity. And that means that we need to identify special populations and individuals with special needs that take a different approach than what would necessarily benefit the rest of our patient population. Value-based care is all about, and value-based payments reward us for identifying who are those special populations that because of their individual characteristics or utilization patterns or conditions are high utilizers of our system. And it's okay to be a high utilizer as long as it's utilization that is increasing their health. But when they're high utilizers and high cost because they're using the emergency room for things that should be done in the primary care practice, when they're high utilizers of inpatient facilities because we are not managing their chronic conditions or we're not helping them self-manage their chronic conditions to where the condition deteriorates if there's no alternative, then that is a waste in our society. And value-based care and value-based payment is all about us improving their ability to self-manage their conditions. So in fact, they're not in the emergency room or in the hospital because to the extent unless absolutely necessary. Our learning objectives for today is to really kind of talk through that and talk about it and let you understand and also let you know what's happening around the country, what's evidence-based in terms of those clinical models, where we're falling short as a primary care system in actually dealing with the needs of the people in our country. So what is value-based care? I like the definition that is from the National Academy of Medicine, which defines it as safe, timely, efficient, equitable, effective, and patient-oriented. And the value-based payments are to reward that type of behavior, that type of incentive. So too often, right now, what happens under fee-for-service is what is the incentive? When you go around to our health centers around the country, the number one wonder for those that have a provider incentive or a care team incentive system is what? They're a little louder. RVUs, which ultimately, because health centers get paid on a flat amount, turns into visits. How many visits can I get done? And the more visits I get done, the more revenue I get done. So that's our current system. Very little of the incentive systems. There are starting to get some that are related to some quality metrics. Certainly, I've yet to see in any health centers that really are getting how well do I do in terms of population health management to provide timely and convenient access to care so people are not having to go to the emergency room for things that should be done here. So I think the result is we're now projecting. So when I was in medical school a little while ago, there was concerns already at that time that what we were spending on healthcare in this country was crowding out the spending for other things, education, housing, other infrastructure type things. And that was when we were spending 13%, and they were worried about that. We're now approaching 20% of our gross national product on healthcare services. It is the fastest growing industry. The expenditures on healthcare are greatly outpacing anything else in our society. So about 4 years ago, and if you haven't seen this, I would urge you to look at this manual. It's actually a 400-page book that is free online. It was published by the National Academy of Medicine that came out in the spring of 2021. And one of the first things they did was they looked and said, what do we envision as far as what high-value primary care should be? Because that really is what value-based care is about, is rewarding high-value care, component of high-quality care as well as cost-effectiveness. So they said that it's the provision of whole-person, integrated, accessible, equitable health care by interprofessional teams who are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships with patients, families, and communities. That's pretty aspirational. We are nowhere close to that as a society, but I look at that resonates with me. And I think for a long time and early in my career, there was this resistance on the part of, and still is, that we are not accountable for patient outcomes. Well, there's some truth to that, and there's some not so much truth into that, okay? So I think what we are accountable for is to providing, the unique needs of our patients to allow them to be self-managed and be accountable. Ultimately, we can't force them to take the medicine. We can't force them to change their diet. We can't force them to change their other lifestyle things, but we certainly can do everything we can. So, for example, one of the things that we did at the health center, which it wasn't not my idea at all, was we created a fitness center. And so we got tired of telling people in our community what you need to do is exercise more, realizing there was not a safe place for them to exercise in our community with all the gang violence and the really limited facilities. So we decided that part of our health ministry was to create a fitness center, which now does about 225,000 fitness visits a year. And we've invested in the clinic has invested in an urban farm. I don't know if any of you saw in Health Affairs. Just this month, Health Affairs talked about the Lawndale's urban farm, which I can take no credit for at all, and really showed the impact of providing healthy food options to our patients, actually reduce weights on a statistically valid solution. So it's really being innovative. Lawndale, over time, because of the church didn't stop with the health center. It created a preschool to do education. It went into housing, it went to legal aid. As it listened to those things on that blackboard and listened to people in this community to say that we need to live out our faith by meeting the needs of our society, those things would lie. And it would then be people in the community that would identify the needs, but also help us solve the needs. We had to be really careful about making sure that they didn't just identify it, but they were part of the solution and they had ownership as well. Well, how are we doing is, let's take a look at just some of the common stuff. So these are 3 UDS metrics that FQHCs have to report on an annual basis back to the federal government. So let's look at hypertension control. There was a dip in a lot of metrics for good reasons in 2020 in terms of the early onset of the pandemic. But if you look at where we are in terms of what percentage of FQHC's patients in the country have their blood pressure at target, it is still the same as it was pre-pandemic. 2019, you can't blame the pandemic for that. In 2023, quite frankly, we can't blame the pandemic anymore. Hypertension control hasn't changed. Percentage of our patients that have a hemoglobin A1C less than 9 has improved a little bit, but quite frankly, what kind of bar is that? How many of you as providers are happy when your patients can finally get their hemoglobin A1Cs down to 8.8? Like, that's terrible control. And why the federal government continues to say that that's what our goal is, which is giving us this false sense that, hey, we've arrived when we get in less than 9. And what about depression? We all talk about how severe, how much it got worse during the pandemic, what all the troubles with adolescent depression, et cetera. How well are we in people with PHQ-9s greater than 10 over time getting their PHQ-9 less than 5, which is considered remission? Single digits. We've got to do things differently. Expectations for patients have changed. There was very little telehealth. It wasn't reimbursable. was always convenient, but it wasn't very reimbursable. But suddenly when we changed the payment system, and this is the lesson, when you change the payment system, you will change the delivery system. And it was pretty remarkable how quickly we as providers pivoted to telehealth when all of a sudden it became financially feasible. So although there's not the still prevalence, but you can see during the pandemic, half of Medicare patients, the group that you would think would be the latest technology, the old folks like me, okay, or still have to call the IT department every time something goes wrong with the computer. You would think they'd be the last group, but they were up to 50% during the pandemic had at least one telehealth visit during the year. It's now down to 24%, but it's still pretty significant. As you may or not know, the federal government is trying to decide whether to continue to reimburse for telehealth visits. Right now, it's only going to be reimbursed through the end of September. We're thinking that's going to change, but all this budget, we may have to spend more money on the military and the border, and we may have to cut back on some services we're paying for in Medicare. Meanwhile, I think as we all look, and this has also been going on for a long time, is the inadequate pipeline as far as primary care providers. And so it's pretty clear the pipeline is inadequate. For a while, we were really hoping that with the expansion of nurse practitioners and PAs, that it was going to completely address this issue. It's not. They're just as inclined to go into specialty care as physicians as well. Our population is aging. As the ages, there's more chronic conditions. There's more need for primary care. The pipeline is not adequate. So how we are using that availability of our primary care workforce and quite frankly, our behavioral clinicians as well has got to change, because we're not going to be able to meet the needs. And when there's a shortage, as I said, it is people who are under-resourced that end up suffering the most. So as you can see, even now that almost 30%, and this has gone up year after year over the last 2 decades. And now 28% of individuals say they don't have a PCP. And those that do can't get in to get seen or are concerned about affordability. So we're still making choices because of our high deductible insurance plans, having to make choices about whether or not we really can afford to go even to the primary care doctor, let alone for some of the other more expensive diagnostic services and specialty care. Meanwhile, we're also, the issue that health centers are feeling is not just attracting and retaining their providers, it's their other workforce as well. And this also got exacerbated during the pandemic. And so we have to think about, well, what is it? Why is that? Why is that? So part of it for health centers is payment, right? We're not going to be able to compete with what the universities can pay for a medical assistant. So if we're going to have to compete on a different way. And the way you compete in a different way is look at job satisfaction. And job satisfaction is looking to see what is it that I am asking my workforce to do that will improve their satisfaction. So think about it. Anyone in here a medical assistant? So what's the main job of medical assistant? Bring a patient, call him in from the waiting room, right? Vital signs, chief complaint, hand them off to the provider. Then while you go to the next room, you clean up the room, you call somebody back, repeat. Well, we need someone to do that. But do they have to do that 40 hours a week? Is there something that way they can have an impact? So one of the models that we're rolling out is hypertension control. So how do we usually take care of people with hypertension? Well, I could tell you when I was in practice which I did practice for 27 years, it's been a while, but there was not much in the way in terms of self-monitoring. So people would come in to see me, and I'm an internist, so I took care of a lot of people with hypertension, and their blood pressure would be high. Well, I never was totally sure, was it white coat effect or not? Blood pressure is up because they were in my clinic. So I usually have them come back another time. Well, every time they come back, I get bill another visit. And, those are really fast visits when you have someone just trying to get their blood pressure control. And finally, I make a decision, I'm going to increase their medication. Well, now, and we wonder why we're not improving hypertension control. Well, now we have the ability to do self-monitoring, and the American Heart Association says that everyone who has hypertension should be self-monitoring with support from their practice. What does support from their practice mean? The support from the practice means that now, hey, at least we're better off because we'll walk in with a list of our blood pressures from home, so I'm not so worried about whether they have white coat or not. Well, that's in advance, but do they really need to come and sit in my waiting room to get that done? In fact, no, we could do that over telehealth. Well, does that need to be done by a provider? Or does it make much more sense for someone from the community who much better understands lifestyle change in their cultural setting, who probably is in many ways a better communicator, And so some people now are starting to say, well, I'll have a community health worker do that. But what about that MA? Who has the relationship with the patient? That MA who's been putting them in the room doing the vital signs, who is the best person to talk to them about, hey, about self-monitoring, helping them to get their blood pressure cuff, making the follow-up call to find out whether or not how their blood pressure is doing, or better yet, use technology with a platform to identify which ones are not doing very well with their blood pressure, and doing the follow-up call with them. So what if I, in fact, set aside a portion of that community, of that MA's time for them to work with the people that they know that have hypertension or diabetes or depression? I got to train them, right? But I can use that workforce, and they're feeling much more better about their job description, because they're also not just doing the things we need them to do, but also they are having impact on the people and they're building relationships. So we have to be creative about how we use the rest of our workforce if we expect to be able to retain them. Clinics were having people go work in the Costco workhouse because, the warehouse, because they get paid $1 an hour more than what they were getting paid at the clinic. What is that saying about the environment and experience that we're asking them to do? So the problem is that we don't like change. We're used to doing things the way we've always done things. It's one of my favorite quotes. Insanity is doing the same thing over and over again and expecting different results. If there ever is a description of our healthcare system, that's what it is. We just keep doing the same thing and it doesn't get better, but then we just keep doing it anyway. So value-based care is a way, the idea of the payment system is to say, can we change the way? So just like we changed we were paying for telehealth visits, change the way we suddenly provided access to care. What if we were to change the way we paid for primary care in general? The idea for primary care too often is when the CFO and the CEO go sign value-based care contracts, whether it's primary care cap or whether it's a shared savings arrangement for total cost of care, it's a financial scheme. And I think there is a pathway towards this. We're going to have to come up with new revenue streams to replace lost 340B. We're going to have to come up with revenue streams to the fact that we're going to have a lot more uninsured people that were previously on Medicaid. They're going to lose their Medicaid because there's going to be work requirements or something else. So we're going to have to come up with new revenue. But it is not primarily to generate revenue. It really is to provide the flexibility for us to redesign the way that we provide access to our care. And by doing so, makes it feasible for us to do some of these models that otherwise are just not financially sustainable. So what are those models? So we have any CFOs in the room? Any CFOs? Okay. What if you go to the CFO? We need to have CFOs in these rooms, they got to listen. But anyway, what if you come up with this great idea? What I realize is a lot of the patients I'm seeing in the clinic, if they could just have called and talked to a nurse, they really didn't need to come in and see me. That happens all the time. So what I think my new idea is, I'm going to go to the CEO and the CFO and say, we should now hire a couple more nurses at, let's say, $75,000 a year between salary and benefit. And now patients don't have to come in. So what does that mean? So then I've increased my cost for the clinic $150,000. What have I done to my revenue stream? Okay, what does the CFO do? He quickly shows you to the door and slams the door behind you, because particularly those that don't really need to be seen are really quick visits. I mean, those of you primary care docs, you realize how nice it is. You're like behind 2 or 3 patients. All of a sudden, someone's come in and they actually got a sore throat or they got hypertension. They don't really need to see you. They could have had the nurse check their blood pressure, whatever. But here's my chance to catch up. Right? So, but do they really need to be there? And the reality is, here's what's happened. We've gone to open access. So that's great. The show rate's much better for an open access slot. Someone calls in, they get it seen that right day. But it gets to be, for many sites, is that by 10 o'clock or 10:30, all the open access slots are full. And with some of those people needed to be seen person, but some of them just could have talked to a nurse. Some of them could have just had a telehealth visit, right, from the convenience of their home. And instead they have been asked to come and sit in my waiting room, but they've taken up a slot for someone that I really needed to put a stethoscope on their chest or feel their belly. And then we wonder so what do we end up telling them? Then they finally get to talk to nurse triage, right? They don't get to nurse triage first in the morning. They get to nurse to triage at 11 o'clock when all the slots are gone, because we got to be careful. And then the nurse tells them whether they can come in another day or whether they just go to the emergency room or urgent care center. So that's how we're doing nurse triage. That needs to change. So I don't have time today to go through all these models, but there are models out here that we can provide much more timely and convenient access to care and get better access and better use of the full care team, but they're not reimbursable under fee for service. What about panel management? So one of the biggest complaints, I do a fair amount of consulting work now, and I work with FQHCs and their IPAs, and they're in value-based care. The biggest complaint I hear about value-based care is you are holding me accountable for for members that are not my patients. It's not fair. I don't have the right phone number. I don't have the right address. Well, how does that happen? Well, first of all, the state Medicaid agency requires that all patients be assigned a primary care provider, right? So patients are given a choice. But typically in most states, less than 50% of patients choose a primary care provider. So then there is some default mechanism that the plans go through. And if they happen to have a claim from the previous that said they went to this PCP, I'll assign them there. And if they got family members that are going to a particular PCP, I'll assign this person there. Or then do they live nearby? And so one of the biggest complaints is that there's this group of patients that I am accountable for that are really challenging to get in for care. Yet, when my quality metrics come out, it looks like, well, my UDS, they love to say, well, look at my UDS. I'm doing much, much better on my UDS for hypertension than I am on the health plan. Like, what's the disparity? Well, the disparity are all the people that are not coming in for care, right? Well, I think for us, panel management is about, we have to figure that out. It is, we can blame it on the patients that don't come in. I'm doing a great job for everybody walks through the front door, but sooner or later, for society's sake, is that we have to figure out how do we engage that population. So, for example, if it's increasingly possible for you to get ADT alerts for your assigned members when they hit the emergency room. So am I responding to those ADT feeds by using, they just gave a phone number and address to the hospital that I have a partnership with? Do I get that information? Better yet, we have one clinic in Chicago that's sending the community health worker to the emergency room at the time for their assigned but not seen population. Because if they build a face-to-face relationship, they're much more likely to get them back. We have to be creative in terms of that. But panel management is about us managing our assigned members, not just our active patients. Now, having said that, there's a long way to go in terms of reconciling who our patients are and who our member panels are. So it's interesting in Illinois, which is where I'm from, and I'm working with the Illinois Primary Healthcare Association, is we looked at what the correlation between of where patients were actually going and where they were assigned, and there wasn't very good correlation. So we have convinced the Medicaid agency, who then turn around and say to the health plans, you will every quarter go back and reconcile. And if someone's been assigned to a particular PCP and haven't seen them in the last 12 months, but they've seen another PCP, you got to reassign them where they're going. So there are mechanisms, there are things that we can start to do. We're talking to the California Medicaid agency now about getting that change made. And I think we're going to see more of that, to at least that, because there's nothing more frustrating for you to do outreach to someone who's assigned to you and they're going to see another PCP and they're just like, why are you bothering me, right? So what are the opportunities of improvement? Implementing a comprehensive transition to care model. So again, right now I do a fair amount of consulting work, and I can tell you universally, one of the things I'll do is I'll have them look at their panel and look and see, of the patients that were hospitalized, what percentage of them came back to be seen in 7 days? What percentage came back in 14 days? And then everybody else that didn't come in within that time period, what was the 30-day readmission rate? There is, without variance, a significant difference in terms of people being back in the hospital again. Now, is that selection bias? There certainly is selection bias of the people that take the initiative to actually come back and make an appointment, but not as much as what I'm seeing. I'm seeing a multiple-fold difference in the 30-day readmission rate. Well, is that good? Is it good? No, it's not good for the patient. And if you're in a value-based care arrangement where you're responsible for total cost of care, it's not very good for you financially as well. So what, again, do we need to do different? So what typically the transition to care, which was advocated by a guy named Coleman out of Colorado. The Coleman model said, make contact within 48 hours of hospital discharge. When we started doing that back in Chicago, so I'm also Chief Clinical Officer of Medical Home Network, which is 14 FQCs, 3 health systems. We have 193,000 Medicaid beneficiaries. We are delegated for care management. We're responsible for TOC, and we're also under global risk, so we're paying the entire hospital bill. When we started implementing the Coleman model, our care coordinators, which are community people, were saying, you know what, we can't find them, or they're not picking up the phone when we try and call them in 48 hours. So it's their fault. And we said, well, what if we actually were to try and contact them while they're in the hospital? Because we're getting ADT alerts that says they just got admitted to hospital. Instead of waiting for the ADT alert saying they're discharged and wait another 48 hours, what if we contact them during the admission? So we did that for a while, and you know what? It made a huge difference, but we were still missing some people. So we said, well, what if we were to risk stratify people to say who was the highest risk of being readmitted to the hospital in the next 30 days? And what if we then sent the care coordinator to go see them in person, face to face? So when we did that data, and you got to follow data to see does it work, we significantly continue to decrease 30-day readmission rate. Now, we couldn't afford with the dollars we had to go see every patient that's in the hospital, but we certainly could afford to go see the people that were highest risk in person that were not usually, and we use AI that takes into account health-related social needs, our claims data, our EHR data, and all kinds of looks to identify who that population is. It was worth it for us to go say, you got to leave the clinic. You got to go see this person who often has never been in the clinic before. Start to build a face-to-face relationship. Care management, as I mentioned, is delegated down the practice level. How many of you pick up the phone when you get a call and on caller ID you don't know who it is? How many of you pick up the phone? See, this is a young crowd, okay? There's always somebody, right? Good, thank you for raising your hand. I've yet to have one audience, but usually it's an old guy that will still pick up the phone and says, yeah, I'm going to do it, okay? But, well, guess what? Care management right now in Medicaid managed care is done by who? By strangers on an unknown phone number in a health plan who knows where physically located. And if someone makes the mistake of picking up the phone and they start doing a health risk assessment, talking about their health-related social needs, like what businesses have viewed, or if they start saying, well, you know what, I'm looking at your records because I got all the claims data here, and what you need to do is A, B, and C, and your life will be much better. Okay, this is ridiculous, but that is how we are doing care management in this country. Care management for a complex patient requires building a trusting relationship, which usually means face-to-face. So at Medical Home Network we are delegated for care management. Those dollars pass down to the health centers who hire their own staff. We have a uniform approach that is monitored by a platform. We are NCQA certified. We have to meet all the requirements to be certified. But then they have the flexibility, and they are part of the care team. And just like we kind of got excited when we started doing behavioral health integration, that when I'm seeing a patient that I could actually do a warm handoff to a behavioral health provider, because it was like not something I do very well. Well, guess what? When someone comes in and I think I'm dealing with their hypertension or diabetes, and they start telling me about their spouses beating them up or about to lose their housing or they can't afford the diet, for me to do a warm handoff to a care manager who is much better at doing that than me, it's not a cop-out on my part, okay? That is the system that we need to do. So care management belongs down at the practice level. Focusing and supports on populations with chronic conditions. I'm going to show you a couple of slides on how well we do as a country in terms of managing. How are we doing on time, by the way? Let's see. 15 minutes. All right, let me keep moving then. Screening and addressing health-related social needs. So we looked at this in MHN. We've published 2 articles now on this. There is this thought that health, it's not just that you have diabetes and hypertension, COPD, but you have a barrier to actually self-managing your condition. Well, that's been around for a while. When we started back, we did these studies starting back in 2014. At that time, there's pretty clear data if you were homeless, that your outcomes were going to be worse and your expenditures can be, no doubt about it. But our hypothesis was much more than that. That, in fact, the things that we talk about now in terms of dietary, food access, et cetera, made a difference. We published those articles because what we did was we screened, and we got 85% of our 193,000 members screened for health-related social needs. And then we looked and combined it with claims data to say, well, first of all, did it make a difference if they had that? And secondly, we'll go back and rescreen them after a year to say, were we effective in actually addressing it? So there's clear data now, and I'm going to show you some other data. There's clear data now that screening and referral actually is predictive of future cost and future utilization. And so it should be part of our risk stratification, and something we should be doing routinely. So along that line, what's the data on this? So as you may be aware, is that there was a large national study supported by CMS across the country between 2018 and 2023. And what they did was they had a uniform screening tool, which is still around, a screen for food insecurity, housing insecurity, barriers to transportation, utilities, and interpersonal violence. But they did something beyond, we've all kind of said, well, yeah, screening and referrals seem good, but what if we actually navigate the patient to see do they get care? Well, what was the data when they looked to see that happen? And there was a subset, because we can't do that for everybody. Just like I can't send everybody a person into the hospital every time someone gets hospital. I don't have the resource to do that. I don't have the resource to navigate. But what does the data show? And what the data showed was that people who had 2 or more ED visits in the last 6 months, they were the group that were going to most benefit, and particularly those that had diabetes and or pulmonary disease. What was the impact on that? When you look at total cost of care for Medicaid, is that, so what they did is they had, some providers are randomized to getting extra funding to do navigation, some were not. The group that got navigated, particularly this subset that had 2 or more ED visits, they looked at total cost of care for Medicaid. It was 3% lower on a risk-adjusted basis. And when they looked at it for Medicare, it was 4% below. So it gives us guidance to say that there is a subset of patients we got to go to the next step beyond doing our screening and referrals to our patients that are frequent in the ED, which is usually an indication when they use chronic conditions that they are not managing able to manage their conditions. How should we provide access to our care? I've kind of made reference to this. Is that when someone calls into the call center, first of all, they shouldn't have to call in to get a preventive visit, okay? They should just be able to schedule that, okay? But in terms of acute management, the triage should be, it goes to the call center, which goes to the nurse, which goes to, when clinically applicable, either to a telehealth visit or to my open access slot. My chronic conditions should be managed, as we've talked about before, but the collaborative care model, people in conjunction as part of the care team to manage our chronic conditions. And in-person visits should be reserved when those things above are not adequate, or we're just not going to have enough capacity to take care of the needs in our communities. And then we need to look at how we're doing for chronic condition management. So this is a routine thing I do with my clients, usually FQHC IPAs, and I said, let's look at your data and let's look and see what are the chronic conditions that are resulting in hospitalization. We focus a lot on managing hypertension, diabetes, and we need to continue to do that. As I mentioned, we're not doing a very good job. But what are the other chronic conditions? So this is pretty common, is that, by the way, the most common one that you'll see on this is actually severe mental illness. We just looked at medical conditions with this. But what this data does is we look and say, well, what percentage of my patients have these conditions? What's the total number, but what's their odds ratio of being hospitalized, or what's their odds ratio of being in the emergency room? So let's look at the odds ratio of being hospitalized. So for congestive heart failure, for this particular IPA of FQHCs, they had 214 individuals, but their chance of being hospitalized was 13.7 times what the average adult member in that IPA. This is all Medicaid. So, okay, that seems like a population that maybe need to take a different approach. So the next thing we did was look and said, well, how are we managing those patients? And this is class C congestive heart failure. So this is systolic congestive heart failure. We looked and we said, well, what's in the literature? What's really clear in the literature, and this is class 1A recommendation. There's no debate about this, which is that they should be on all 4 classes of these medicines, if at all possible, if they can be tolerated. And we should escalate this over 42 days. Within 6 weeks, you should get somebody on all 4 of these medications. Well, what does it look like nationally right now? I'm not talking about FQHCs. Any of us is less than 20%. Less than 20% of patients with Class C CHF are on all 4 classes of medicine. Now, some of them just can't tolerate all 4 classes. But 54% of people that were even discharged recently from the hospital for exacerbation of CHF are even on 4 classes. Well, does it make a difference? What does the literature show? Well, literature shows that if you're on one of those 4, your chance of being, some of them are on none of them, your chance of either dying from or being back hospitalized for exacerbation of your heart failure is 32% reduced. If you're on 2 of them, it's down 44%. And 3 of them, it's down 55%. And if I put them on an SGL2, which pretty soon is going to be in the water for everybody, but it's another 25%. What does that mean in terms of how long people live? So if I'm not 80, I'm getting up there, okay, but I'm not 80. But if I develop heart failure, I want to make sure I'm all 4, because that's going to give me an extra 2.7 years of living for an 80-year-old, 1.4 more years in terms of being hospitalized. Well, what if I'm only 55? Now I've added 8.3 years of longevity. Is there any question about this? Why in the world? I mean, I can tell you that most FQCs are not even running the data they're not even running the data to tell how we're doing. I mean, when I go to these FQCs and IPAs, they haven't run these reports. Then they run the reports, say, "Oh my goodness." We all recognize that it's not just that there's a continuum now. Like people lifestyle and inaccurate exercise, obesity goes on to hypertension and prediabetes, which goes on to diabetes, which goes on to chronic kidney disease. And a lot of our focus on chronic kidney disease about, well, I'm concerned about people going to end-stage renal disease, and you should be concerned about that. But we're realizing that they're 4 times as more likely to die from a cardiovascular disease than they are to go to end-stage renal disease. So it's all one continuum, okay? So what is the treatment for that? Okay? They should all be, so once they get to stage 3 chronic kidney disease, so first thing we do when we work with our IPAs is we look and say, how many of your patients actually have chronic kidney disease is not on the problem list? Any idea what I typically find? So we just run the lab and sort of say, let's look at the lab. You have 2 GFRs less than 60, at least 3 months apart. And is it on the problem list? What percentage of people with CKD do you think is it on the problem list? Half. Now, what's 2 most common conditions we're dealing with in our clinics are hypertension, diabetes in adults, right? And what's the leading cause of chronic kidney disease by far? Hypertension. So first of all, we're not treating their hypertension, diabetes. Then they get CKD and we don't recognize it. And when they do recognize it, we don't treat them with the right medications because all of them should be on an ACE or ARB unless there's a contraindication until they get to be on dialysis or close to dialysis. They should all be on a statin because of their increased cardiovascular risk. And they should all now be on, again, in the water, SGLT2 inhibitors. What's evidence-based in terms of care management? Evidence-based care management is we've got to risk stratify our patients, and we got to get away from buying stuff off the shelf. So what do we do when we do risk stratification? When I go to health centers, what I see is that some of them will come up and say, well, I think that 1 + 2 + 3 is going to equal 6, so this is my high risk. And they'll assign totally arbitrary. I mean, it blows my mind. Totally arbitrary. And there's a little logic, people with certain chronic conditions, and they'll add a little health-related social needs, and they'll come up with this algorithm, and they're going to risk stratify based on that. Or they will buy something off the shelf. So they'll go and they'll buy, John Hopkins risk stratification, which is based upon claims data and eligibility data. So it's demographic and it's disease burden, and it does help, okay? But as we just mentioned about, does the John Hopkins take into account the things that you guys see when you're seeing patients in the clinic, which is those health-related social needs? Does it take into account whether the patient's taking their medicine or not? Does it take into account whether or not they're showing up for their medication? You cannot risk stratify using this simplified approach. And the only way to do this is to use artificial intelligence, which at MHN we've been using for about 6 years now. And again, we published on that as well. As you can't, these factors are all changed. There's so many factors that are changing all so fast. You cannot possibly come up with it using the scientific method of here's my hypothesis, and to come back a year later only to find out that you're wrong. So we have to move towards artificial intelligence that takes in data in real time. So we re-stratify our patients in real time. With an ADT alert, their risk stratification score changes. And we are delegated, as I mentioned, for care management. We have enough funds to do care coordination for everybody, but care management for 3.4% of the population. Who is that 3.4% of the population that we can impact? There are some people that are high cost you really can't impact, but who is that? Well, the only way you're going to be able to do that is to use AI that is taking these multiple sources of data in real time. We get pharmacy-filled data every single day. Someone's taking their medicine or not. We know if someone was discharged from the hospital, did it show up to the pharmacy in the first 24 hours. So we really need to move towards this and make sure that we're using what limited resource we have for care management to the population that's most going to benefit. So what are the arrangements? So most health centers in this country have progressed from just fee-for-service to pay-for-quality. Pay for quality is great, okay? It's typically aligned with your UDS, some preventive services, hypertension control, diabetes control. Well, that's fine. I'm not saying it, but we can't say we've arrived. We're a high quality clinic because we've managed hypertension, diabetes, and get people cancer screening. And so we have to move beyond that to accountability for managing total populations, because once we're accountable for managing total populations, is that we also start to see we got to go beyond that to say where are the patients that are high cost, high need that we can intervene and improve their outcomes so they're not having to depend upon the emergency room or hospital. So the first step is capitation. You mentioned capitation. So our health center, as I think I mentioned to you, we were one of 5 health centers in Chicago that first developed a capitated APM in the country. I can tell you I went to NAC conferences and I had to wear a bulletproof best because there were people that were really mad at me because we were giving up PPS. It does not give up PPS. The federal rules are really clear that if you move from fee-for-service to capitation, your capitation has to equate at the end of the year as much as you would have got paid under fee-for-service, if not more. But I can tell you how many angry people were angry with me. I stopped going to NAC conferences because they were just so angry. But what capitation does is, again, as we talked about before, says, how do I best use my care team? How do I improve access to care in a way that is convenient? I mean, how many of you still, the only way you go to the movie is to go to the movie house? The only way. Good. There's a couple of people still left, but most of us stream because they listen to society and they said, okay, I want to be able to stream movies from the convenience of my house at time. And there's a definite ambiance to going to a theater. I go to a theater once in a while, right? But most of the movies I watch, I'm doing it when I want to from the convenience of my house. When we started the health center, we were handing out paper checks, and when we take our paper check, we go stand at the bank. Okay. And then it went from that to kiosk. Then now you're banking from home. We go to the bank. When was the last time you walked in the bank? What's happened to all the good? There's always somebody, right? Good. But I mean, what's happened to all the big fortified buildings or retail stores, Gap or something else, because we don't need them. Okay. What's happened to retail? Most of what we're buying, some people still want to be able to go and browse, and that's fine. But most of us are shopping over retail. Healthcare has not changed the way it provides access to care. And if we're not careful, we're going to end up. So the whole question for us FQCs, are we going to be in the front end of that? Or are we going to be on the back end? I'm telling you, if we're on the back of it, we're in trouble. Just like there were industries. So Kodak is pretty famous because they had their camera business, and they were pretty early. They could have done digital technology, but they were afraid it would compromise their film business. So they stuck with the film business. Where are they now in terms of how many of you have a Kodak camera here? Yeah, right. Okay. That could be FQCs if we're not careful. So my last slide is this change management. This requires us to be innovative, to be risk takers, calculated risk takers, okay? But allows us to change. And I can tell you, any of this, when you do it, the first response is, we've always done it this way. This is crazy. We're not going to change. And I'm not trying to sound unnecessarily alarmist, but what's coming down the road to us as health center, between losing our 340B or a lot of our 340B, from realizing that our patient-payer mix is going to deteriorate. We're going to have more uninsured, less Medicaid. What we're going to have to continue to pay our workforce from competition. And unfortunately, there's not going to be another ARPA grant. The cavalry's not coming. So either we change our business models, or we're going to either have to significantly downsize. We're going to have to let our faith-based clinics get merged into another health center that is stronger, that may have a very different culture. So it is imperative on us to take this seriously and think about what is it we're going to do differently under the new environment. So I'll stop at that point and give time for questions. I would say there's two different payment models. When you look at how you get paid for your direct services, it really needs to be more than half, which is why for us it needs to be the Medicaid population for our health centers. The reason why is because as you move to capitation, if you have too many freeloaders, in other words, those health plans that are paying you fee for service, and now all of a sudden they put that nurse triage, they're benefiting, you're using your resources. Right now I'm working with the Center for, first of all, there's a group called the Primary Care Association Value-Based Care Collaborative. It basically are the CEOs of the PCAs from 44 different PCAs around the country. Almost everyone is there. We've been meeting for now 3 years in terms of value-based collaborative. We just got asked by Abe Sutton, which is the new director of CMMI, to come back with an FQC proposal. I've worked with CMMI for the last year on a project under Making Care Primary because it's the first time they allowed FQCs in. So I've been their advisor for that. So I can tell you what CMI is thinking is CMI is very much intent about moving you from fee-for-service to capitation. I think there are problems in how they did it in the previous models, and we have some thoughts about that. But they also want you to do it within the context of total cost of care, and they want you to take risk. So that is what's coming down. So our proposal that we will go to Abe Sutton this next week is that this has to be not just Medicare, it has to be Medicaid. And I can tell you the models of care that you put in place for your Medicaid and Medicare will translate to your uninsured under your 330 grant. I mean, think about it. You're not getting a PMPM for your uninsured, but you're being paid prospectively, and it's all about prospective payments. The incremental dollars you get, what do you charge for an uninsured? $25 on a low end, something like that. What it costs you to provide that service in person versus the virtual care is much more than $25. So if we can get a model, and what we have is we're going to start with the states that have already moved towards capitation or doing that. So if we can move our Medicaid, our Medicare, and continue to get our prospective 330 grant, we can change the way we provide access to care. Then we're talking for most health centers, Dave, I would say we're up to like 90%, and it really becomes feasible. Good question. Others? Yeah. One of the first things that's really important with that is to make sure you really spend time and effort on empanelment. Because otherwise they'll say, well, you're holding me accountable for somebody that's not my patient. So you really need to put effort into empanelment. And then you need to they need to understand what your value-based payment arrangements are. What are the quality metrics? What's the efficiency and utilization metrics? And you got to then start to track the data that way and parse it down to them. But you can't do it if you haven't first done a really good job of empanelment. And then ultimately you have to decide. I mean, at Lawndale, we never did individual care team or physician incentive. What we did was that when we were profitable on our managed care contracts, is we put a portion of that into reserves, which is what we had to do is we took more risk, but we set aside part of it for the entire clinic. And so the amount of money that got distributed was based upon the fact that we had margin left in our managed care. So there's not that kind of same short-term incentive, which we know is effective, but was is the direction we went that turned out to be. So what we did is when we made money off of managed care is that some went to reserves, some went into clinical initiatives to improve our performance in next year, and some of it went to incentivize our staff. Like it used to be, every one of your clinicians will say they got the sickest population, right? Okay, right? I got the sickest patients, that's why my numbers don't look as good. But we would track hemoglobin A1Cs, hypertension, whatever. We also would look at what not only their number of visits, but also the number of average conditions that they address during that time. That does not work for pediatrics because your most intensive visit is a well child visit, so you got to take that into consideration. But we would track and say, well, look, this person is addressing an average of 3.5 conditions per visit, and this person's doing 1.2. So your 1.2, don't tell me you have a more complex patients, or you better start coding. And how much of that sometimes is doctor's perception versus and I mean that honestly, is that when we moved to capitation, there were some people that thought, well, first of all, what happened in Oregon when they moved to capitation in 2012 is that their productivity went down like this. And the thought was, okay, now it doesn't matter. I'm not being paid per visit, so now I'll spend even more time with my patients. What we have to do is we have to take a care team approach, and all of us need to be working at top of our license. Should happen under capitation, the financial model, because as I do more of a care team approach, I got to have money to pay for those other care team members, right? Which means that I need to manage a larger panel without telling my docs to work harder. So it is all about then doing that transition. You're absolutely right. There is some resistance. And sometimes you have to people are different in terms of their expectations, but I think what really helps them too is to know what do they really want? They want to be able to call and get an appointment. They want to be once they show up, that they're going to get seen on time. Those things are actually as important, but continuity of care is also important as well. But continuity of care, they gradually have to move towards a relationship. Well, again, if you're using your MA, I'm not introducing a stranger into this. Okay, it's all about, so they will adjust to the model change. It's hard for them just as it is for you.